Good afternoon. I'd like to thank the SMSNA and the moderators for the opportunity to present today. I have no financial disclosures, however the views in this talk are mine and not that of the US government. So I've broken this talk into three different areas that we've seen some advances to the IPP literature over the last few years. We'll start by talking about infection prevention, discuss revision cases, and conclude with a couple different intraoperative and perioperative considerations. So starting with infection prevention, we're all very familiar with the AUA recommendation for antibiotic prophylaxis and IPP surgery, but that guideline was really founded before there was any good studies to guide a specific regimen in prosthetic urologists. And this was a nice population level study from Brandt and colleagues that looked at the impact that the guideline had on the prescription patterns of prosthetic urologists. In the figure, you can see the dotted vertical line is 2008 when the guideline was initially published, and after that point, gentamicin in red and vancomycin in blue both increased substantially and is now the most frequently used regimen among prosthetic urologists. In this study from the pump group, we wanted to assess just how efficacious the most frequently used regimen that we just saw was, which is Vanc and Gent, compared to all other regimens. So we looked at over 4,100 patients undergoing primary PP placement and found that Vanc and Gent was actually associated with an increased risk of implant infection. We also found that antifungals decrease the risk of infection in all comers, not just high-risk patients such as diabetics. So from this study, we really advocate for using local infection histories and local resistance patterns when trying to choose the best regimen. Another area within infection prevention that there's been a lot of excitement is with different irrigation solutions, one being Irricept. In this study from Dr. Cartman and Dr. Henry, they took Titan disc, coated them with Irricept, exposed them to many different bacteria that oftentimes cause implant infections, and then irrigated those discs again with Irricept, which has a high-pressure nozzle on the bottle. And they found that this protocol had really good kill rates, especially compared to their control group of saline. So our take-home points for infection prevention is that it's really critical to be thoughtful about how we select our antimicrobials, as this is key to infection prevention. Antifungals appear to have a benefit in all patients, not just high-risk patients. And the initial work for different antiseptic solutions is encouraging, but more work is needed to really assess its efficacy in clinical practice. So moving on to revision surgery, this was a nice study from Dr. Lentz at Duke, where they took patients who were undergoing revision surgery at their institution and broke them into two groups. So the first group were those patients who were having revision surgery with exchange of any or all components, and the other group were patients who were having revision surgery without exchange of any components, so just repositioning of a pump or cylinders or something like that. The mean time to revision in the component exchange group was 48 months and only 5 months in the repositioning group, but when they compared these two groups, they didn't see any difference in infectious outcomes. In this multi-center study, we looked at a similar but slightly different question. So we took just patients who were undergoing revision surgery for mechanical malfunction and broke those into two groups. So those who had the entire device replaced versus those who just had the malfunctioning component replaced. And you can see that our cohort was very different than the last study. The time to revision is 168 months in the complete exchange group versus only 44 months in the partial component group. But in general, this cohort was much further out from surgery than the last study. And when we looked at our outcomes, there was a really high rate of non-infectious complications in the partial component group where it was over 20%. And when we looked deeper at that cohort, pump-only revisions had the highest rate of complications, where 3 out of every 10 patients had a non-infectious complication. And in the pump-only revisions, the overall complication rate approached 45%. And then the last revision study that I'll talk about is from Dr. Morey, where they looked at a really interesting question, which was what are the differences in mechanical indications for revision between Boston Scientific and Coloplast devices. And in the figure, you can see that Coloplast, which is in green, had almost exclusively tubing failures, whereas the Boston Scientific failures were more evenly distributed among all the components. So take-home points with revision surgery, that our current studies really challenge the conventional wisdom of just replacing the problematic component in mechanical or in revision for mechanical malfunction. And complete device replacement may decrease complication rates, and ultimately that may translate to less surgical morbidity for our patients. And there's different patterns of failure between our two different device manufacturers, and this is important when trying to plan surgery if you're planning to only replace the problematic component. And so now moving on to an intraoperative consideration. This is another study from the pump group where we wanted to assess any differences in single dilation versus sequential dilation. So one of the fears with single dilation is that you don't adequately dilate the corpora and may undersize the implant. So to do this study, we did a matched cohort study. We had almost 400 patients in each group, and we excluded any patients who had corporal fibrosis or known risk factors for fibrosis, as that might select out for sequential dilation. But after excluding those patients, we found that there was no differences in cylinder size and also no differences in intraoperative corporal complications like perforation, crossover, and urethral injury, which suggests that in non-fibrotic corpora, single dilation is safe. And then the last topic that we'll touch on is one that there's been a couple different papers that have come out, and that's prolonged scrotal drainage after implant surgery. So the first study from Dr. Osmanov and Dr. Wilson, among others, was a prospective study where they had 3 groups. So patients had no drain, group 2 was drained for 24 hours, and group 3 was drained for 72 hours. And they found that the 72-hour group had a lower hematoma rate at post-op day 10, and when following the patients out further, there was no differences in infection risk between all 3 groups. And the other study from Shoemaker in the Journal of Sexual Medicine was a single-arm study where they looked at patients who had drains for over 48 hours and found an overall infection rate of 1.4%, which is really consistent with large multi-institutional studies of patients undergoing primary IPP placement. So our take-home points here are that single dilation is safe, at least in patients with non-fibrotic corpora. Prolonged scrotal drainage appears to decrease our hematoma rates and does not increase the risk of infection. With that, I thank you. Look forward to taking questions. And if you could scan this QR code and take our infection prevention survey.